I am delivering this presentation on behalf of Dr. Sonja Hess, who was unable to come and sends her regrets. This presentation is delivered on behalf of all of the co-authors of this work that was a publication. I also want to say that none of us had declarations of conflict. So as we've already talked about the consequences of anemia and the critical poor outcomes, the adverse effects. We've heard this several times today, so I won't go through this in the consideration of time. However, all of this has led to an incredible focus globally, as we know, on the global nutrition targets, the publication in 2012 of the World Health Assembly resolution for the Comprehensive Implementation Plan on Maternal, Infant, and Young Child Nutrition, which of course explicitly included a 50% reduction of anemia in women of reproductive age. And critically then, all of the two Sustainable Development Goals that were already mentioned today by other speakers, 2.2, ending all forms of malnutrition, and Target 3, ensuring healthy lives and promoting well-being for all ages. This was setting in the context of the global burden of anemia, which we know is really incredible. We've seen this already today. I think the major take-home that strikes me as incredibly important is that the number of women with anemia globally in 2019, pregnant and non-pregnant, was equivalent to over 500 million women. So when you think about 500 million women having this serious consequence and potential adverse effects, it really underscores the need for the global targets and the emphasis that we're raising on anemia, and we've been doing during this whole day in recent years. Similarly, I just want to reemphasize that everyone remembers that while there's a huge global public health burden in the African region specifically is really, the highest at over 60%. The last point that I want to make before the next slide is that a lot of the data that went into modeling this 2019 global burden was actually based on data collected in population-based surveys that used hemoglobinometers, like HemoQs, and we're using a single drop of blood, which Lisa, mentioned it briefly, was addressed in the guideline that was recently published, and we're going to hear a lot more about later. But just keeping in mind that this does raises some questions about the accuracy of some of these estimates, especially when we're looking at them longitudinally. So I think the most important thing we want to know is that between 2000 and 2019, there hasn't been enough progress. Again, we've seen these slides, similar slides earlier today, and this lack of inadequate progress is also part of the momentum we're seeing now, the focus on anemia, and the fact that we need to be focusing on this. There really was not, significant change at all among non-pregnant women, a slight reduction among pregnant women between, this time period. Very little change for children under 5. So it's important that we're not seeing enough reduction is the issue that, we're all aware of. Fortunately, that there is more of a shift to mild anemia, and the prevalence of moderate and severe anemia has declined in most populations and regions, which actually is a quite important finding. So with that in mind, we now have the focus on how to really address this issue. We have the global anemia targets set by the World Health Assembly, but what do we need to do next? So I will point out that this slide deck was made before the framework was published in May of 2023 by WHO, the Comprehensive Framework. So this Global Action Plan is actually not the correct name on this slide. It should be Accelerating Anemia Reduction, the Comprehensive Framework for Action. So whenever you see this, just think of the framework instead. And importantly, this has then also led to the development of the Anemia Action Alliance, which Lisa described earlier today, really bringing together stakeholders to really, think about how to do this differently. So the whole rationale for this presentation then was that this was one of the 4 input papers that was developed in order to inform the development of the Accelerating Anemia Reduction Comprehensive Framework for Action. So this was one of those foundational papers. And so the objectives then of this are to really describe briefly etiology of anemia, major gaps and way forwards in knowledge and on the causes and the risk factors. And then you'll see some of the key citations that were relevant. I will say I'm going to attempt to not repeat a lot of what was done today, but maybe give you a little more information, deeper information, more nuanced information than we've seen, so that to avoid some of the the redundancy. So, as we well know, anemia is clearly a consequence of a wide range of causes and biological, socioeconomic, and ecological risk factors that are context specific. But explicitly, I want us just to remember that there are three main underlying physiological mechanisms of anemia. So you get it through ineffective erythropoiesis. So that means the body produces inadequate numbers of erythrocytes. Hemolysis, meaning the erythrocytes are destroyed, or blood loss. This is partly why anemia is so complex, because it can develop based on all of these different mechanisms. So in the next couple of slides, I'll talk through some of the major drivers of anemia and the mechanisms through which they're causing anemia. Iron deficiency, we've all heard of this, plus other nutritional deficiencies, but really iron deficiency is a major cause globally. The Global Burden of Disease study has estimated that about 60% of the global burden of anemia is due to iron deficiency and other nutritional causes. You know, we know that iron deficiency is the most common nutritional deficiency leading to anemia. But it really depends. So it depends on the infection burden, it depends on where you live in the world. So in some contexts, it might be 30% or less, and others it could be, you know, as much as 3/4 of the cause of anemia in a given context. So that's partly why this issue is so complex. We know multiple other vitamins and minerals might also be co-occurring you know, with anemia or be causing anemia. Typically they tend to maybe not have as much of a contribution to anemia as iron does, but it is context specific. If we look at inherited red blood anomalies, the Global Burden of Disease study estimates that about 15% of the global burden of anemia is caused by these anomalies. I think it's important to note that many countries do not have population estimates of inherited red blood cell anomalies. That's an important thing to keep in mind with each of these causes. So for the thalassemias, we know you get anemia because of abnormalities of hemoglobin synthesis. For sickle cell disorders, it's because of changes in the hemoglobin structure. Other hemoglobinopathies because of the gene variants. And then you have abnormalities of red cell enzymes, especially something like G6PD. I'll tell you that when we looked at this in Nepal, everyone was astonished what the prevalence of G6PD was and how much it contributed to anemia. That was one of those things that no one expected. It wasn't the thalassemias there, it was G6PD. So I think we all have assumptions about what might be causing anemia in a given context, but that's why it's important to measure it, to actually see, to have evidence-based understandings of the causes. And then, of course, abnormalities of the red blood cell membrane causing some of these other issues on the slide. Infections, this is a really critical issue. The Global Burden of Disease study estimates 12% of the global burden is due to infections. However, this is one of the really complex issues because infections, of course, vary by context and where you live geographically in a country, in a region, in a continent. So we have things like soil health, soil-transmitted helminth, including various parasites that lead to blood loss, and that's why you have anemia. Schistosomiasis, similarly, is a parasite that leads to inflammation and blood loss. Malaria alters iron metabolism, and this is a really complex, important one, especially for this continent. It doesn't lead to iron loss, but because it alters iron metabolism through mechanisms that include hemolysis, release of heme, dyserythropoiesis, deposition of iron in macrophages, and inhibition of dietary iron absorption, all of these things that Jonathan raised earlier today. So this is really understanding the infection, inflammation, malaria continuum for iron status and infections as anemia it's really complex, and it's really an important gap right now. HIV has multiple mechanisms, so it's ineffective erythrocyte production, hemolysis, blood loss, and it's also a side effect of the treatment, which also causes anemia. And TB, which is frequently, especially co-occurring with HIV, leads to chronic inflammation. Other conditions, here it talks about gastrointestinal disease and kidney disorders, lead to blood loss, decrease erythropoiesis, destruction of erythrocytes. This actually is really common, especially in in a lot of parts of the world. And the Global Burden of Disease study estimates 13% specifically to those diseases, to those conditions. So gynecologic and obstetric conditions it seems like it's obvious, but menstruation, this affects such a huge percentage of the population. Pregnancy-related risk, such as iron deficiency due to increased iron requirements in pregnancy. I mean, think of third trimester pregnancy. It'd be surprising if you were not iron deficient. And then, of course, potential blood loss during and after childbirth, and especially things like postpartum hemorrhage, which can, result in a lot of blood loss. And then we get in all the risk factors that increase anemia through really all these different pathways. So low socioeconomic status, which is related to poor living conditions, poor access to water, sanitation, and hygiene, increased exposure to air pollution, increased exposure to smoking, increased food insecurity, poor dietary quality. And then this, of course, is also linked with low attainment of education, just even your potential to, have, the economic productivity of your life, ability to understand and access information related to health, nutrition, or family planning. And then actually healthcare access and use of healthcare services. If you live farther away from health facilities, you have this distance decay effect, where you just have less access and less ability to use these resources. And then, of course, gender inequality and cultural practices, especially those related to early marriage and pregnancy, can have really important roles in increasing risk for anemia and the other causes of anemia that then contribute to it. So this is a adapted conceptual framework, which some of the slide might be cut off, but that's okay. And so we developed this framework as part of producing this paper. And some people have criticized it as sort of being like, oh, you made this like super complex framework, which I get. But I think it's drawing on the fact that anemia is complex. And I think when you oversimplify it, you kind of miss how all of these things are interrelated. So what I want to do is bring your attention to the different levels that we see in the framework. It's defined by underlying risk factors, then the intermediate risk factors, and then direct causes, where it's not that these don't all interact, but the framework really focuses on showing the interrelationship of these direct causes, because it's not like they all just go directly to anemia. They're interacting with each other in terms of the pathways that then lead to anemia. So it might be those going directly to cause anemia, it might be that they're influencing, micronutrient deficiencies are influencing inflammation. So it really is trying to sort of capture the interrelationship of that. And then we have what we had talked about earlier at the bottom, were the direct, the physiological mechanisms. So, decreased ineffective erythrocyte production, hemolysis, blood loss, then all of these things come down to then, leading us to anemia. So it's complex, but I think it's meant to really reflect the fact that anemia is complex, because if this was an easy problem to resolve, we wouldn't be, talking about lack of effective reduction over the last couple decades. It would have been resolved by now. And just to sort of highlight again that hemoglobin and anemia they're conditions and they're really indicators of health and poverty overall, right? So that's another element that we can't lose sight of. So there are quite a few important gaps that we do want to highlight. It's kind of been mentioned earlier today about how we don't have enough data in many ways, but I just want to point out, if you look at this figure, based on 432 nationally representative surveys since 1990. The fact that there's only been 432 surveys since 1990 was quite surprising to me. And 64 countries don't have any population-based data on anemia. And then when you see who they do have it on, it's on, reasonably, the population groups that are at highest risk. So, we see the first four bars on the left here are young children, women, adolescents. And then we really don't have a lot of information on other population groups that might have different risk factors and also, need intervention. We mentioned a little bit about the different kinds of data we need. I think this is just hemoglobin data. So if you think about the fact that we want nationally representative malaria data, well, that usually comes from malaria indicator surveys. Well, guess what? They do young children. They're not doing the adults. So we might have data on malaria for children, but not necessarily adults. Similarly for soil transmitted helminths. Whereas if you look at where the HIV/AIDS surveys are done, those are done really on older populations, and you don't really have much data for the young children. So the data variability really varies for a lot of different reasons. And so you really need to be thinking about triangulating where you can get these different data sources. I think someone mentioned earlier using DHIS2 data, thinking about electronic health records. So we're not just going to get it from one source. It's potentially not only going to be population-based surveys, but ideally it would be with subnational disaggregation. I already mentioned that there's very few population-based surveys of inherited blood disorders either. So that's really another huge gap. And so then getting at the technical concerns related to hemoglobin assessment, Lisa mentioned this a little bit in the previous conversation, and we're going to get into this further in later presentations as part of this workshop, so I'm not going to mention much now, but this is a really critical issue, and it's really important that countries, as they're moving forward, seriously consider really only using probably venous blood samples moving forward, recognizing we're still learning about the possibilities with pooled blood and other issues, but there's a lot of concerns raised there. And then I kind of already got into the point of the accurate attribution of causes of anemia rely on information on the prevalence. I already mentioned that we don't necessarily have prevalence data for all the causes. But it does matter from the point of view of, things like the global burden of disease study. The way they work is they're looking at shifts in hemoglobin due to a cause and the prevalence of that cause. And so when there's gaps in data, they're also using proxies and sort of assumptions, and this influences the modeling that we have. So when you don't have data on inherited blood disorders, you might really be miscalculating how much of that is actually related to anemia globally. So it does have implications both for global estimates as well as your own, national domestic estimates. So really trying to think critically about how to get all of this, as much of this data that's relevant to the context is really critical. Okay, so hemoglobin, as we know, is the biochemical indicator most frequently, assessed in population-based surveys, especially among women of childbearing age and children under the age of 5 years. The additional data that we need to be brought together for in-depth analysis of the risk factor and causes of anemia at the national and ideally subnational level, we've been covering that specifically because understanding the etiology of anemia is really important. We know that we can't really design effective and targeted programs without this. It's important to consider, especially also, that with cross-sectional data, you cannot make causal attribution, and most of the data we're talking about really are cross-sectional prevalence surveys that you're bringing this data together to model and do other statistical analyses with. And so it's important really to remember and to think critically about what are the strengths and what are the limitations of the approaches we're using to our analyses when we're trying to say this is what we think are the correlates of anemia or what the population attributable risk is, and really thinking critically, like, is this really an appropriate method that we're using to make those statements? And if you're not, or if you are, what are the limitations of your approach? It would be great if we could have more de-identified data publicly available for surveys and other mechanisms, as well as sharing properly stored biospecimens for analyses of additional biomarkers, both of micronutrient status and infections, which will depend on the micronutrient you want to look at, the biomarker, the matrix, the lab method, but nonetheless, it still offers more opportunities. And then ideally then, using the data we do have to then understand where we still have other gaps is really critical. So in terms of collecting new data, countries with potentially high burden of anemia or outdated or limited data on the etiology would preferably be prioritized for the collection of new data. I know quite a few number of countries here actually have been doing this and have a lot more new data available. So it really serves as good examples and models that we can learn from all the different countries that are here. For newly planned surveys, it's not too difficult. I'll talk about this in the next presentation as well. The inclusion of specific indicators is feasible, in many survey settings, and they should be driven by the context-specific considerations. So obviously, if you don't have malaria in your country, you don't have to worry about malaria, but everyone here probably does. The type of blood collection, we were just mentioning this, venous blood. If you're doing a lot of biomarkers in general, you probably need venous blood regardless. And then also the analytical methods are really important to be focused on. Lisa mentioned really the focus on high quality on the pre-analytical, analytical, and post-analytical. And then there really is much less data available on adolescents, especially the younger adolescents. We're talking the 10 to 14-year-olds or older persons, a lot of different other risk issues going on there. However, we need to consider what is the anemia risk in a given context and the potential burden of relevant causes, and then cost is always an issue. Monitoring and evaluation clearly is important, is critical, for prevention programs that are targeting major causes of anemia. So, a very specific example is malaria surveillance. It's a key aspect of interventions in countries that are malaria endemic or have eliminated malaria but remain susceptible, and they get lots of funding for this. And they have routine surveys, and these systems are integrated and available. So anemia, as we know, is a consequence of a wide range of causes, often which occur simultaneously, and understanding the causes and risk factors for different population groups is essential for the appropriate design and implementation of policies and programs and effective interventions to prevent and treat anemia. Clearly, this means we need a coordinated approach across various expert groups and programs to make the best use of existing data, or to advocate for the collection of new and relevant data, especially in countries with a high anemia burden and limited information on the etiology of anemia. So just, to get back to that main overarching point is there's been a lack of progress over 20 years or more on reducing anemia. We have all these global targets that we're not achieving. Everyone in this room knows that malaria can result in anemia, that, some micronutrient deficiency can result in anemia. We've known this. So if we all know this, why didn't it work for the last 20 years? So I think the point we want to make here with the Anemia Action Alliance, with the global framework for anemia reduction, is we are purposely making a different approach because we need a different result. And we think that the outline of how we've been developing this framework, how we've been pulling together the Action Alliance plans, how we've been interacting and engaging with all the country partners who have so much experience and so much to contribute, that it's really critical now to think about what do we do differently? Because if we keep doing the same thing, I don't know why we'd expect a different result. But we can do it.